Yeah, good evening, everyone. Thank you for the opportunity. And at the outset, I would like to congratulate ASG Academic Cell for carrying out this fifth session of Learn from the Masters. So previously, we have had very great discussions as described by Dr. Kaushik. Today, we are fortunate to have Dr. Ahmed A Sallam with us. He is Director of UVIT Services and Associate Professor at Harvey and Bernice Jones Eye Institute, University of Arkansas for Medical Sciences, UAMS. Sir is an ex-fellow of the prestigious Moorfield Eye Hospital, London. He has an extensive experience in medical and surgical retina and has over more than 70 peer-reviewed scientific papers to his name. Sir will be sharing his experience on the art of scleral buckling today. The panelist for the sessions is Dr. Dinesh Talwar, sir. Good evening, sir.
Good evening. How are you?
I'm fine, sir. How are you doing, sir? So, sir is a senior vitreoretinal surgeon with Center for Sight Eye Hospital, New Delhi. Sir is an ex-consultant from RPC AIMS, New Delhi. To add to sir's lots of accolades, he is teacher of teachers. He has been an editor of the book Community Ophthalmology and Indian Perspective, and also assessment strategies in ophthalmology, a panoramic view. Welcome, sir, and thank you for being one of the panelists, sir. We also welcome Dr. Anand Rajendran. Good evening, sir. Sir is a chief of vitreoretinal services and head at Arvind Eye Hospitals, Chennai. He is also a national chairman of scientific committee VRSI. We have seen organizing amazing VRSI conferences under Sir's able leadership. He is also a chief editor of VRSI national newsletter, and Sir has many. Sir is also a reviewer in many peer-reviewed journals.
Thank you. I was the chairman.
Yeah, during Lucknow conference, sir, and I've been following that. Sir was the national chairman scientific committee. Yeah. The third panelist for today, Dr. Kasinathan N. Welcome, sir.
Thank you. Thank you.
Sir is a senior vitreoretinal consultant at Chennai. Sir was an ex-consultant at Shankar Netralaya, Chennai. Sir is a president and president of the Retina Interest Group of Chennai and also an examiner of FRCS examination Glasgow. Moreover, he is a reviewer in many peer-reviewed journals and an avid researcher with many papers to his name. So, welcome everybody. Thank you for gracing the occasion. So, may I invite Dr. Ahmed Sallam, sir, to start his presentation, and Dr. Atul, to moderate the session.
Thank you so much, Dr. Ravani. I will. I'll upload my. I'm delighted to be here and seeing lots of friends that I've met over the years. So, really, thank you so much for the kind invitation. So I don't have any financial disclosure. The question is, I'll start discussing scleral buckle, and as I say, I'm more than welcome to ask me any questions once I finish the talk. And I think the importance really is in the discussion, and that brings up, as my boss used to say, the nitty-gritty bits of surgery. The discussion is the main thing, really. So how does scleral buckle work? We know that scleral buckle closes the retinal break from outside. If you have a break, you push on it from outside, you push the scleral choroid and RPE in, and that closes the break. But if you have that and then the effect of the buckle goes away, then the break is going to open. That's why we use retinopexy, whether cryo or laser, is to cause a permanent adhesion around the tear. So this is important to understand. And we'll talk about this a little bit more in the coming slides. So what are the outcomes of primary retinal detachment surgery? So people talk about 90% success rate for vitrectomy and even 100% success rate for vitrectomy. But in reality, we don't see this. This is a retrospective big study from
I think he accidentally got muted.
Okay, can you hear me?
Yeah,
I
yeah.
do. Yes, now.
Oh, okay. Shall I? Have you heard the beginning or?
No. We could
Start the
Okay.
slide again.
Okay, I'll start very quickly. Yeah, I apologize for that. Thank you so much. It's great to meet friends here, and I'm grateful for the invitation. How does scleral buckle work? The scleral buckle works by closing the break from the outside. So you push on the sclera, the choroid, and the RPE, and you move that in towards the retina. But the problem is, if you do that only, the retina would reattach. But later on, if the buckle slackens for any reason, then the tear is going to open. And that's the problem. And that's why you have the RPE adhesion made by the cryo or the laser. So the question is, what's the outcome of scleral buckle? Now, in the era of vitrectomy, we see better with vitrectomy. Why just don't we do vitrectomy? And the answers come from big study, because if you ask surgeons, what's your success rate for primary vitrectomy? They would say 95%, 96 and 99%. But really, we don't see that in big studies. This is a big study, 5 centers in the US. And what they found is a success rate of 83.1% or 83% for vitrectomy in retinal detachment. And that's another big study from the UK that I did. And we found actually a similar rate. The rate is not 90% at all for primary vitrectomy, but the rate has been consistently high, or at least on the high side, for buccal surgery. So we know that it works at least like vitrectomy, if not better. And data from even the US study showed that it had better vision. And we've seen now work on retinal displacement, and we know that buccal with no drainage, you have less retinal displacement. And similarly, what we found in the UK study. So just for the sake of discussion and for young people joining us, you can classify into this type, into the material. You have solid silicon or you have sponges. You can also have other buckles like balloon buckle or placing injectable material in the choroid to achieve a suprachoroidal buckle. And that's another way of classifying it, whether it's segmental radial or it's segmental circumferential, or you have an encirclement buckle. I just want to mention something here that I apologize that the slides are playing up. When you have an encirclement, it's having exactly like a belt around your waist. That's a permanent effect. As long as the belt is there, the bucket effect is there, because you're not depending on sutures. You're mainly depending on how much you've tightened that belt around your waist. So it does have a permanent effect. Okay, let me move on with the slides here. Okay, what's the indication of primary scleral buckle? So in my practice, the indication of primary scleral buckle is what we call a no PVD detachment. And usually that happens in young patients. And usually it's in the form of atrophic holes in myopic patients or a dialysis, and that's usually traumatic. Also, I use it if there's a localized PVD detachment. So the usual type of detachment in all patients. If I think it's a localized one break or two breaks next to each other, especially if it's inferior, I'd like to do buckles as well. But my main indication is number one, and that's for me is a solid indication. I will not do vitrectomy in these cases for many reasons that you all know. It's difficult. The hyaloid is attached. Sometimes there are lattice everywhere. Once you insist on causing a PVD with vitrectomy, you end up with many, many breaks. In many cases, you cannot really remove the hyaloid. People tend to worry, put oil, and you've completely disadvantaged the eye doing vitrectomy in these cases. While with a scleral buckle, as the U.S.A, it's a slam dunk. You just put a small buckle there, it's done. Okay, let's talk a little bit about cryopexy. So a few just tips here if you're doing cryopexy with retinal detachment. You always want to make sure it's happening with the tip. Very, very unlikely you'll be like treating somewhere else with a tip while the shaft is treating another area. And the worry is that the tip will like go to the macula and you'll be treating the break with the shaft. Very unlikely to happen. if you're aware of this picture, the indentation with the tip has a very characteristic appearance. It's like a big mountain going up, while the indentation with the shaft doesn't look like that. You have to be gentle with the cryo, especially wait for it until it thaws and remove it, because if you remove it while still freezing, you can break the choroid and get suprachoroidal hemorrhage. And the thing is, what if you're doing a scleral buckle and the cryo doesn't work? Because we know cryo is a very notorious machine. You're very lucky if you have a cryo machine that works every time. If you remember the first slide, cryo is actually not important at all in the early period. So if cryo doesn't work, you don't need to do cryo. You just put a buckle, retina attached, then you do laser later on. And that later on can be after a month. Cryo is not important in the early period. Cryo is important when the retina is attached and you're worried that after 6 months, as the sutures start to loosen down, that the tear is going to open again. That's where you need cryo or laser. So cryo doesn't work, no problem. And just treating the RP is fine. It doesn't need to reach to the retina as long as the retina is going to fall on there afterwards. Okay, let's talk a little bit about encirclement. I know, I'm sure you all know the encirclement. There are two types of encirclements or two ways for doing it. One is with sutures like this, and that's here an encirclement with buckle, which my indication for this is really very limited. It's a case where there's retinal detachment with PVR, but the PVR is not enough to do retinectomy. So I just want to relax the retina. That's mainly my main indication. Otherwise, I don't like mixing vitrectomies and scleral buckle. I don't think there's any need. So I wouldn't do this in a primary retinal detachment. My only indication, PVR, that is not enough to do that is not enough to do a retinectomy. And that's here. And the sutures mainly, I usually do them about 4 millimeters from the muscle insertion backward. And something very important to remember, these sutures do not dictate the height of the buckle. What really dictates the height of the buckle is the amount of shortening of the buckle. These sutures are just to prevent the buckle from moving anteriorly or posteriorly, but they do not dictate the height of the buckle. So you can do it this way. And then here it's a paracentesis, you want to high buckle and then a Watsky sleeve and then shortening. And you want to eyeball from the outside a gentle indent, and you can maneuver it. And usually some shortening is more than making it very tight. Or you can put it, as we all know, with encirclement belt loops. And that's where you make belt loops in the sclera, as you can see here. And I like this technique, but you have to be cautious at the beginning, because the problem with this one, if you perforate, it's not only a needle perforation, it's like a ruptured globe now. So I wouldn't use that as you're learning the technique, but later on, I think it's nice, it's cool, you avoid sutures, and it's a very elegant way of doing it. But I would avoid that at the beginning if someone is learning, because again, if you perforate, it becomes a difficult situation to sort out. Okay, moving on from this, what buckles I use for that? I usually use a 240 or a 41 band. They are small, they're nice. And again, my only indication, as we discussed, if there's PVR, but not enough to do a pneumatic retinopexy. Okay, let's talk about suture placement for localized buckle. And that's, I think, the important bit. So usually this is what I go with, is about 1.5 to 2 times the width of the buckle, usually gets it right. And landmark. The landmark, and that's usually my go for buckle, is a 510, which is a 5 millimeter buckle, but half a cylinder. This is the one I like to use. The landmark for a radial buckle is the middle of the tear. So I would mark the middle of the tear, then I would measure about 1.5 to 2 equidistance from the middle of the tear. While my landmark for, like here, for example, would be 7.5 millimeters centered on the buckle. While my landmark for a segmental buckle is different. I do they say oro-occlusive buckle. So my anterior landmark is the muscle insertion. And then I measure from that landmark, where the arrow is. This is the landmark. And then I measure posteriorly 7.5 millimeter posterior from there. And this is why the idea of the oral occlusive buckle. Sometimes as you put the buckle, you don't put the buckle in the right place, especially with the parallax. So you end up putting the buckle a little bit posteriorly. So then the anterior part is not covered. So you want to avoid that situation. And the way to do this is with segmental circumferential buckle. Always you do the anterior sutures just behind the muscle insertion. That occludes that area, so you don't get this anterior gutter, and that prevents redetachment. So for me, that's what I usually do. I like to keep it simple, and that's what I do with segmental buckle, circumferential. Okay, this is $1 million question: to drain or not drain. We know that draining improves the tear-buckle relationship, but the problem is you have up to 10% risk of subretinal hemorrhage, which can be really serious. So drain all cases, some cases, no cases. So what I usually do, these are my indications for drainage. Chronic detachment, you need to drain. The fluid takes long time, and sometimes it doesn't go away. So I usually treat them. The other main indication is a poor tear-buckle relationship at the end of the surgery. I'll show you. So here, I'll come to that, but let me talk about drainage site. Where do you drain? I mean, basically you want to drain where there are lots of fluid, but we know for a fact that, like here, the red dot, but we know that the vortex vein are more towards the vertical meridian. They are in the oblique areas of the quadrants, but they are more towards the vertical meridian. So that's why you want to be draining more towards the horizontal meridian. So they always say along the borders of the horizontal recti is good. If you have to drain vertically, go under the vertical muscle. But I would try to avoid drainage vertically. Okay, these are good. So you finished the surgery, you've done the buckle, you did not drain, but this is the appearance here. That you have the tear is nearly on the buckle, but you have lots of fluid behind. Fine. I think this is absolutely fine. As long as the tear and the area where the tears are is conforming to the buckle, this is fantastic. It's going to work. But you don't want that. You don't want the retina that is not really conforming at all to the buckle. That this is not going to work. And I'll show you here something here. This is here at the beginning, and this is here afterwards. So you have the tear on the buckle. The tear is at the edge of the laser, but you have more fluid posteriorly. The reason is it got pushed posteriorly. That's fine. That's absolutely fine. This is going to work fine. Otherwise, so I wouldn't worry about that like fluid there backward. Otherwise, then you will have to drain. There are lots of drainage methods. You can cut down, prepare the sclera. And this cut down is nice because you open the sclera and then you prepare the choroid, so your risk of bleeding is much less and it's more efficient. Or you have the prank technique where you just make a drain. This is quick. You have less risk of incarceration because it's usually a very small opening, but there's a higher risk of bleeding. And that's why you need to understand how to manage the pressure. With the cut down, you need a normal eye pressure. So I wouldn't press so much on the eye. While in the prank technique, you need to have a high pressure for two reasons. The opening is small, and also your risk of bleeding is high. So as you're doing it, you need to be pulling on the recti muscles or pressing on the eye with lots of cotton buds as you're doing it. Best to think of drainage and air as one step. So I'll show you here. This is a buckle here placed. This is what we call the bed of the buckle, where the sutures are. So you got the buckle here in place. And now drainage is preferably done in the bed of the buckle. So if you have an incarceration or anything, it's covered by the buckle area. So this is just thinning, and then a prank technique with a 26 gauge needle. Note here that we're pulling on the muscles, and then after that inject air, and then after that you have a look. So it's best to think of this as like a single step. You drain air, then have a look. I would resist the temptation to have a look before, because you don't want to go into hypotony, especially if you're using the Brank technique. And you can see here a fantastic buccal-tear relationship. That's another way of doing it, where you're making a cut here. And then after that, you prepare the choroid either with diathermy or laser here. And you can open the choroid with this. So you have less risk of bleeding, you have a bigger opening. And you can help puncturing with a needle as well. But you prepare the choroid. Here, I wouldn't put too much high pressure on the eye, but you need to have like a reasonable pressure, like a normal pressure. And I say, I usually think of this like you do this, you inject air, then you have a look. Okay, what about the techniques? So basically, there are three techniques. One is with the indirect, we all know. This is the classic. You have a good view, but the problem is the ergonomicity and the teaching. Second is you can use a chandelier, like the second picture. And third, you can use a modification like a trocar, which I really like the third one. I started doing the chandelier and I like the visualization, but the problem is if you move the eye, it keeps falling off. So then I thought, let's use the trocar. And I thought I came up with this, but then I found other people describe it. And I think it's really nice because it doesn't fall, the trocar is there, you put the light in once you need it. And I think all this concept of endo-illumination is fantastic in terms of ergonomicity and teaching. The problem is coast vitreous traction, and also there's a potential risk of endophthalmitis. I always suture that port. There's a nice study that came out from an Egyptian group that showed increased risk of epiretinal membrane by about 50% on OCT doing this technique, but that did not translate into clinical ERM, which I think is a small price to pay for the ergonomic value, and most important for the teaching value. Now you can teach that to fellows, while with indirect, I think it's very difficult to teach. Let me show you a case here. And again, so I usually put the trocar superior, like I'm doing a vitrectomy, opposite to the quadrant of interest. And one thing I like to do before opening the eye is I put those patients usually to sleep because they're usually young. And I would do a 360 scleral indentation with the indirect before opening the eye. For me, with buccal, I want to know exactly what I'm doing before opening the eye. And I find that helpful. I just revised the plan. In many cases, I did not have the chance to indent those patients in clinic because they are very young and it's difficult to indent. Then I would open the eye and put the trocar superiorly opposite the area of interest. Here, this is the step of localization. And I double check this. This is the main thing. So I hold here with a tooth forceps. And I will check again and make sure this is the plan here. This is the tear here. Fantastic. So now we're in action. And now remember what we discussed, the landmark is the middle of the break. And that's here actually a senior resident is doing the surgery, which is so interesting. There's a guy who went on to do a fellowship in Texas and stayed as a faculty there. But it's very easy to teach. Now cryo, and remember cryo doesn't work, no problem. Now we're intending not to drain here, so paracentesis to soften the eye. And here now suturing with non-absorbable suture. And that's me holding the suture for him as he sutures. So it's really great. This is a PGY4, which is like third year ophthalmology, going into a retina fellowship and can do a nice buccal here because you can see what they are doing. You're teaching them. It's all very obvious what's happening. While with the indirect, this is really impossible. All right, now we look good. And then you just finish off. And then here, and then you just finish off. And I would always suture that port and suture the conjunctiva. So question here, this is a very nice case from my friend, Dr. Asim in Sweden. can you buckle that case? So that was a young patient near PVD with chronic detachment, and the tear is here. This is the tear. So the question is, can you buckle that tear? And that's a good question. And yes, he buckled that tear. You can see here the tear is on a radial buckle. And there's a small depigmented spot, which I'm sorry, I should have put an arrow on it. Oh, I did. The green arrow here, that's where he drained. So then something that, you take from this is the equator, which is marked by the vortex vein. If the tear is anterior to the equator, you can definitely buckle that. If the tear is the equator, you can, but it's difficult. So that's a nice landmark. The other landmark is when you indent patients in clinic, if you can reach to the tear, then you should be able to buckle it. So those are the two landmarks I go with. Most breaks are easy to buckle, but I would always remember the surgical equator as a landmark. I have a YouTube channel. These are the videos there. There's like a channel, like what is it called? Like a play group for scleral buckle, and you can find cases on scleral buckle there. I'm in the process of renewing the YouTube channel, so hopefully in a few weeks it should be up and running again better. But there are lots of videos there. And thank you so much for having me.
Thank you, Dr. Ahmed. Hello, can you hear me?
Yes. Yes.
Thank you, Dr. Ahmed, for a wonderful talk. And now I would like to open the discussion. And first of all, I'd like to start with Dinesh sir and you. That in which case you will not go for the buckle? In a 19-year guy is coming, and in which case, what are the non-contraindication for the buckle in that case?
I think the only one is a giant break with the flap being folded. I think that's three would be my main indication for vitrectomy in this age group. But even if the patient has PVR and does not have that configuration, I would go for a buckle.
Other than a giant retinal tear, if you have a very posterior break, a detachment with a very posterior break, where I estimate that my buckle will come more than 20 millimeters behind the aura, I will probably not buckle.
Yeah, obviously, yes. So a folded flap or a very
I have buckled at 21 millimeters also previously and 22, but that's not what I'll do now.
Yeah, no, I think that I agree. That's probably is the case.
Yeah, I'd probably also just add that, if you find areas of extreme scleral thinning, when you're seeing the conjunctiva, if you think there's a lot of scleral thinning, especially myopes, that is also something that we often encounter. Then those are the cases again, I might not want to buckle.
And one more important indication would be a patient who has a very severe hypotony with a very bullous detachment. Chances are he has a choroidal detachment in addition. Again, these cases are better handled with a vitreoretinal surgery.
That's what I was about to say. When there is an associated choroidal detachment, better not to buckle, because with the cryo itself, the incidence of choroidal detachment is going to increase. So those are the cases. And traumatic retinal detachments, or when there is associated with some trauma and open wounds, then buckle is not a choice.
Also, just to add, if the media is not clear, if you have a small pupil, then those are also cases you wouldn't want to.
For the choroidal detachment, for me, I would avoid cryo, but I would just put a buckle. And later on, if the retina attached, you can do laser. Because one thing as well, which might be nice for young people starting surgery and buckles, what you want to see after the buckle surgery in the early post-op period is a good tear-buckle relationship. The RPE scarring is not important at this stage. Once the retina attaches, a tear-buckle relationship is not important. What's important now is the RPE scarring around the tear. So I think that concept is important. I'm not saying don't do buckle while you're doing the surgery, just do it and get on with it. But I think it's important to understand the difference, what you're looking for.
I come to this case which you showed us, one of your friend's case which you shared, it had an inferior choroidal detachment as well.
Right.
Avoid
Yeah, I would avoid, I try to avoid cryo in these cases, just do a buckle and then later on come and laser it.
And see, SRF drainage becomes a problem if there's associated choroidal detachment. The height becomes more difficult to adjust, and tackling the choroidal in the presence of a RD is another issue. So that's one major issue, one major situation where a vitreoretinal surgery probably makes life much easier.
And hypotonia after the drainage will aggravate the choroidal detachment.
Yeah. So overall, there is, see, a bullous detachment, you're going to drain more. You end up with an hourglass figure. You don't want to. Now you say, I won't do a drainage. Then you've got a choroidal which won't go away. So it's a messy job when you have a choroidal which is the indication is severe hypotony. You get to know from that. And if you've got a bullous detachment. So that's one situation. Even when it's phakic, I would say I would go in for a vitreoretinal.
But those cases are rare in young patients, right? Because
young
usually
patients,
with the hyaloid intact, yeah, they don't go into bullous detachment.
Usually that kind of hypotony would occur if there's a giant retinal tear or something, not in the usual case. That's true. Yeah. Let's take the reverse. An indication for only doing buckle. For me, the situation where I would preferentially want to do a buckle is a patient who has a moderate height of detachment, a detachment which is going at least to the to the horizontal meridians in one side or the other, and the break is anterior to the equator. This is an ideal situation for going in and doing a buckle, because you have everything going for you, and the chances are you won't have 90% success rate, you'll probably have 99% success rate.
I also agree. I would just qualify that a little more and say, young phakic patients, especially with an inferior fresh detachment, these are cases that you definitely want to, and also pediatric detachment cases, like I think you mentioned as right at the top of your, indications. Yeah. Hyaloid is notoriously difficult to detach. So those are absolute kind of indications for buckle.
Yeah, one thing to remember, what happens is very often you say myopes, try to do a buckle. But remember, in myopes, you can get a false appearance as to the break being anterior when actually it is quite posterior. So the important thing is to indent and check. If you can indent through the lid, you can buckle. There's absolutely no problem in that. If you can't indent through the buckle to the posterior part of that break, be careful. You may actually end up at a 22 millimeter buckle, 22 millimeter suture. So I don't want to distort the eye so much, even if it's myopic, and otherwise things would favor a buckle.
That's what
okay, sir. Okay, sir. Take one.
If you can depress the break in your clinic and your OPD, then that's buckle.
Yes. So that's the best way to check.
Yeah, I agree.
Okay,
I think sure. Go ahead. So I think that's the most important take home. I think you mentioned that in your second thing when you show the ultra wide field angiography, and you said secondarily that you should try to break. I think the most important thing is to be able to buckle those, to be able to indent those. So skill with indirect ophthalmoscopy for buckling, it's an absolute prerequisite. I think that's critical. Yeah.
Dr. Ahmed, take one hypothetical situation. If a 16-year guy is coming with a supratemporal dialysis and bullous RD with simultaneous macular hole, traumatic macular hole, whether you will go for the buckle or not in this case?
Yeah, I would go for a buckle. I would go for a buckle and leave the hole for now, and then deal with the hole later if it stays. Usually it will close.
I think one should keep in mind that if you do a vitreoretinal surgery in a dialysis, you're converting what is an easy surgery into a giant retinal tear. So not a great idea.
Okay,
and
okay,
you
sir.
can always handle the buckle. You can always handle the hole separately. In
and
fact, it's easier to handle it separately.
Usually it will close. I mean, traumatic usually they close, and also holes with detachments, they usually close. They may not, but they usually close.
Most of the time it's because of the retinal edema. So spontaneous
Yes.
closure has been reported after traumatic hole. So you deal the dialysis, just deal one at a time. Just deal the dialysis with the buckle and the hole will close. If it doesn't close, it's easy to do a macular hole surgery in an attached retina than in a detached retina.
Absolutely.
Okay, the next question is, Dr. Sanam, in all of your cases, we have seen you are using the sponge, not the tire. Means why you are going towards the sponge only? Because in India, we are using mainly the tire.
Yeah, honestly, I don't know. I think sponge you get a better height, but I think the risk of extrusion and infection might be higher. I used to use 277 and 276. I did not have like a smaller sponge, so I think a smaller tire, like a smaller solid sponge. Maybe that's why. But generally, I don't encircle. So I would still maybe use a small solid silicon as a circumferential or radial, but it's just easier for me to find the sponge smaller, like 5 mm. That's the main reason, really.
So
I think if you have a single break, maybe a sponge would work out well. But if you've got multiple breaks, it's probably better to put this solid silicon circumferential buckle. And I actually prefer a 276 or 277.
Yeah.
Usually the asymmetric one, and the advantage is it's not too high, so the chance of creating an abnormal bulge, is also less. We used to use the 5 mm buckle before, which was much more thicker, so it was much more ungainly. Very often you could see a protrusion under the conjunctiva, but with the 276 or 277, that doesn't happen much. So I personally have a preference for those, and I rarely, and as you said, we used to see with the radial sponges too much of extrusion and more of infection, so we actually stopped doing them. So
Yeah,
word of caution,
and
word of
I-
caution,
Kasi sir,
yeah, when word of caution when you use the sponges, the actual buckle height will be much more on the next day because the sponge gets swollen with the water or saline. So the actual buckle height on table might be lesser. So you should not think the buckle height is less and you should try to tighten more. The next day you'll see much bigger buckle heights. That's one thing with a sponge. And sponge, you can use it for fish mouthing. One of the best tool for a fish mouthing of a horseshoe tear, I think sponge is the best one compared to a silicon tire.
We've
Dr.
also
Anand?
moved away
gas.
from sponges quite some time back, because again in India, we have this concern with infection, and extrusion was an issue with this, so we've definitely moved. We don't do radial silicon tires, but I know of people who do that and do that quite well also. But we prefer segmental,
actually, the
just
curve is
tires.
not. Frankly speaking, the curve doesn't conform so well to that. So I wouldn't like to do the tire as a radial element.
Yeah, I know we don't do it, but I know people who do it.
In case you have a fish mouthing after a circumferential buckle, probably the best way is to put a little gas or a little air even.
Correct. Air works very well, provided that is superior.
Superior.
So that's what. So usually that will take care of it.
Yeah. Also, just resuturing. Very often this, since we are on fish mouthing, I think very often this happens because people, the ends of the box suture is very close to the edges of the buckle. So like Dr. Salam also mentioned, you need to have at least 1 millimeter, at least, if possible, even more, gap. So that otherwise what happens is the sutures are grabbing the buckle, and that leads to stress internally and a fish mouthing effect. So if you just redo that suture, relax it, and
basically it's too much
keep it
circumferential
away.
tightening.
Yeah.
Yes,
So the
exactly.
Circumferential
the contour
tightening
has
is
to
too
be
much. You'll
smooth.
get a radial.
Yeah, so avoid
fold,
high buckle.
and that will cause a fish mouthing.
So I think in big breaks, try to put a radial, not a circumferential. Also avoid high buckle, avoid tight suture, because that will lead to high buckle. And as mentioned, gas or air, if it's superior, works very well. I think I agree. These are all great points.
One more thing in the same context, how many of you are doing the radial buckle in the era of beautiful vitrectomy machines?
I told you we gave up on radial buckles. I mean,
we never really subscribed to that.
so
Radial
for the last, I don't think last 2 decades, I've been using radial buckles. I used to use them when I was in AIMS, and then we used to use it very, very frequently. But sometimes even 2 or 3 radial buckles for 3 different areas, but not now.
About more than 12 years ago, 15 years ago, we used to use sponges.
Yeah,
like Dr.
radial
Sallam
sponges,
used.
basically, not
Sponges.
buckles. It
Not
was
buckles.
basically the silicone sponges, but sponges, I think, have a higher incidence of infection. So actually, the kind of sponge that Dr. Salam was using, I don't think that causes as much infection. But at that time, we didn't have them. At the time when we were using radial sponges, we didn't have them. And now I think they are available, but now we've moved on.
And so what is your steps, Dr. Ahmed? What is your step if you are doing a 24-year guy and around 3 o'clock, one break is there, large break is there, bullous RD, almost total bullous RD. What is your surgery? Whether you will go for the drainage or not? Even
Okay,
if
that's
the,
a good question. So what I would do is that I usually, those patients are young, I put them to sleep. So usually I like local anesthesia with little sedation, with vitrectomies, but with buckles, the patients are usually young. So I cut the discussion and I just put them to sleep. Before opening the eye, I usually have a plan in the clinic, but in many cases, you cannot indent those patients in clinic because of the reasons we discussed. They're young patients. So then I would, before opening the eye, I would indent 360 both eyes, look for pathology in the other eye, and make sure that my plan is still so. So as Dr. Dinesh has been saying, like if you can reach the buckle, the tear nicely, then you can buckle. And also make sure there are no other breaks. Other breaks in attached retina are not going to change the plan because I will just touch on them with the cryo or laser them later. But what may change the plan if there are breaks in detached retina, which could be like using a pneumatic as well at the end or changing the plan of how I'm going to put the buckle. Then after that, I go ahead with the plan, open the conjunctiva. I usually put the trocar superiorly opposite the quadrant of interest. And I go ahead with like what I showed you. Then I put the bucket on the tear. And if I'm not planning drainage, I'll do a paracentesis, put the bucket on the tear, tighten, see how it looks like. If it looks good and the area where the tear is conforming to the buckle, then I don't need to drain. If it looks like the area where the tear is like really high off the buckle and is not like talking to the buckle at all, then I will have to drain now. So that's what I do. And if I drain, for me, drainage and air is one step. Drain, air, keep pushing on the eye, because usually I do a prang and then wait and then have a look.
okay, why are you not going for the saline? Because air will hamper the view.
I don't know. I think few things. The saline may go through the break, but that's fine. I mean, I think air closes the break better. And I think if you are, because even if it like hinders your view, you're just, you know what exactly you're looking for. You're looking for just forming the eye and you know where the break is. What you want is to see like, okay, there's no problem. The retina looks better on the buckle. That's it. I don't want like to examine every part of the eye again under air.
That's
so I think air forms the eye quicker and closes the break better.
I agree with Dr. Salam. See, that's why in a buckle, you need to do a lot of pre-planning. Whereas in a vitrectomy, you can take the decisions on the table. Whereas in a buckle, if you have done a good homework and a good plan, see, most important step in a buckle is the localization. If you are pakka with your localization, you can get away with any complication of the buckle, the incarceration, perforation, everything can be taken care if your localization is pakka. So that's why there is a lot of pre-planning is required in a buckle. So injecting an air for forming the vitreous cavity, the forming the eye, it's not going to be a great issue because the buckle is on the right place.
So
Totally agree.
personally, I prefer to use air only when you have the brakes in the superior quadrants. One, because I'm using air primarily not for visualization, but for tamponade. So for those purposes. And secondly, I think when you mentioned that the air for visualization, you're talking of where you have a chandelier in, Dr. Salam, and then you're using the biome and the microscope? Or is it with the indirect?
No. So I don't. So before open the eye, I would examine with the indirect.
Okay, but then after
But
that,
once I open the eye, that's all the recite or the chandelier or the
okay,
biome.
so then the buckling is then from that point onwards with a microscope assisted
Yes,
or
with a
chandelier
microscope.
assisted
Exactly, microscope and a wide field light.
wild field light. Yeah, so in that situation, yes, perhaps. But then in India, which is a resource challenged nation, and insurance is not freely available. So opening a chandelier, it can be a little overkill. So I personally think buckling should be done with. We used to do. I mean, Kasi and Dr. Dinesh would also agree that we used to do buckles about a decade and a half ago. We just had a light, which like a tube kind of, the kind that we used to do dacrocystal rhinostomies with. So it's that cost inexpensive. So what I would think is air to be put in when you have superior brakes and when you're using it primarily for tamponade in such situations. Otherwise, it can be a challenge, especially for beginners, to see through air. So that's that's the only one take. And if it's not superior, then I would go with saline.
No, I actually have a little difference in the way I go ahead with the buckling procedure. As Anand said, I actually hate to inject anything inside an eye where I'm doing a buckle. I don't want my extraocular surgery to become an intraocular surgery. I don't want anything inside the eye. That means inside the vitreous cavity. So what I will do is I will, as we've been talking about it, first thing is, in a buckling procedure, your pre-op evaluation is the most important thing, and is not only the most important thing, it has to be done meticulously so that you know exactly what you want to do, because your visualization on the table is not as good as your visualization pre-operatively. So that's number one. So I mean, anybody who wants to do a buckle and says, "Main to table pe hi dekh lunga," I don't think many experts have also said that's the way we would like to go. So then once you've done that, now the second thing is, when I go in, after doing the peritomies and the muscle hooking, I will first put all the sutures. I'll put the sutures for the encircling band and the buckle, all of them, based on my localization. And frankly speaking, I have a fairly accurate idea of my localization. I've already seen I'm around the equator. I want my buckle is going to come, the posterior suture is going to come around 18 millimeters. I may want to confirm it, usually will, but even if I don't confirm it, I know I will be on the right track there. Once I've put the sutures, I pass the encircling band first. And there's a reason for this. This is like my bridle for tightening and loosening, so that I never let hypotony occur during the surgery. At no point of time during the whole surgery will hypotony occur. And this is one of the major fears we have when you're doing a buckle. After that, I'll even place the buckle without tightening. So nothing is tightened, everything is in position, no pressure is put. And then I do the drainage with what we call a modified needle drainage technique, which we described 2 decades ago, in which all you need to do is tangential to the point where you want to drain. You introduce the tip of a 26 gauge needle only up to the level of the bevel, only up to the level of the bevel, and you will find the fluid will start flowing. You take it out, you don't leave it over there. So now, unlike the other techniques where you sometimes leave the needle inside, which I feel the longer I leave it inside, the more I'm scared that it may cause rubbing on the choroid. So the needle goes in, comes out, and the drainage keeps on happening. While this drainage is happening, I will keep an assistant who will press in the area of maximum drainage, maximum fluid. So he's pressing from there, fluid is continuously coming. My endpoint is when a little bit of pigment starts coming out from along with that fluid. And now I will Keeping this in position, keeping the buds in position so that the pressure is maintained in the eye which has been pressed, I will turn the eye around to expose the area of the band and tighten it. Now, when you tighten this with the buckle already there, and then you slowly remove the buds, you find that you ended up with low normal to normal tension, depending on how much fluid came out. So your pressure is maintained through your entire surgery. Now I have a drained out retina, the drained out fluid. I don't have any risk of any RPE getting migrated into the subretinal space. And that's when I do the cryo of the points wherever the breaks are there. In an retina which is attached, no parallax problems. You know exactly where how much cryo to do. No over cryo is done. And after doing that, now you see now the time this is coming through, you have time when the pressure is also building back again from the low normal to normal. You keep on tightening the buccal sutures to the exact level you want. I check the height that I want. I make sure that the tightening of the encirclage does not exceed 12 millimeters. And you can measure 12 millimeters. So for me, it's a mathematical thing. 12 millimeters translates into something like 1.5 to 1.75 millimeters of height of the encircling band. And that's just the perfect height that you need for a buckle, for a buckling surgery. And after that, the surgery is over. So there, at no stage is there any hypotony. The drainage is completely safe because there's no risk of any incarceration. There's no choroidal nothing. No chance you'll make too big a hole. The only risk is of a hemorrhage during the subretinal fluid drainage. And for that, the most important thing is that you do, under the indirect, you make sure that you have the area from where you're going to drain has no ribbons. When you indent, you can actually see they'll now, once you're indenting, there'll be whitish ribbons, though they're otherwise pink ribbons. Wherever those ribbons are not there, and there are virtually an avascular area if you go on either side of the horizontal recti. So that's the safest. That's why I said it should come up to the horizontal recti, takes away the risk of more choroidal vessels in that area also. In fact, Dr. Sallam showed a photograph. You see the watershed areas are best just around the horizontal recti. So I mean, this is a little different from what people will do. It's a little different from DACE also, you know, the drainage first technique which came. And I don't like to put air because it affects my visualization. In this technique, the visualization is perfect through the whole procedure.
One thing, Doctor, how about doing a cryo after placing the buckle? So it's going to be difficult, right? After placing the buckle and band.
No, because it's not tightened.
Okay.
So usually, in fact, you know, one of the risks which I've seen a senior resident once cryo into the disc. And that happens because it's an open eye, he pressed, and as Dr. Sallam was saying, the shaft was mistaken for the tip. A tip for that also. When you do cryo, go from the periphery and keep seeing the edge, the indentation of the cryo and moving it more and more downwards. Never accept what you're seeing as just one thing where you haven't actually moved into that area as the area to do the cryo. So that will prevent this problem. And having the buckle actually prevents it completely because you can't go too deep. You can go only up to the level of the depth of that, the area of the buckle.
And that's a classic teaching what we say when you have a break. First, cryo the anterior edge of the break.
Yes, so that's why. So go from the anterior edge.
From the anterior. Even if you have a mistaken that as an anterior, the cryo is going to be only the posterior part of the break. Yes. So you have to first cryo the anterior, then go posterior. So what we do in Shankar Netralaya when we were there, it was first is localization, then you do the cryo to the break, then you take the sutures, you measure it, then put the sutures accordingly. What we do is 3 millimeter posterior to the break, that will decide the tire size, and then 2 millimeter extra for the sutures. For example, the break is at 5 millimeter, then 3 millimeter more is 278, means 8 millimeter. 8 millimeter means 278 tire, and you put the sutures at 10 millimeter. So that's a thumb rule for the placing the tire. And then we try to drain most of the time, not at the bigger break, because if you drain at the breaks, then you'll have a lot of vitreous coming in. So you have to be adjacent to that or in the horizontal meridian. And we use a technique where we make a sclerostomy, and then cauterize the bed, like Dr. Sallam has said. And what we use is what you call the 10-0 silk, the curved needle. So we use the curved needle to make a break, rather than going vertically perpendicular, you just use a curved needle and then to drain. And then once the drainage starts coming, what you do is as the drain, when you see the pigments, immediately what we say before drainage itself, you have to keep certain things ready. You need to have a 2cc syringe with saline filled in, or if you're planning a superior break, you have to keep the air ready. So after the drainage, you cannot do all the knee-jerk responses because you don't want hypotonia and suprachoroidal hemorrhage. So you have to keep the saline and the air ready. Once you see the pigments, then what I tell my assistant, because in a buckle, the most important is not only the surgeon, but you need to have a very good assistant, unlike the vitrectomy. So here you need to have a trained assistant for a buckle. So immediately when I see the pigments, I tell my nurse to hold on the suture, recti. I just tell them to hold on the 2 horizontal recti. So holding the horizontal recti gently by pulling it, not too tight because you can get an incarceration, gently pull it and then just feel the pressure and then inject the saline. Most of the time it's a saline which we inject, and then we tighten the buckle. In an hypotenuse globe, if you are going to tighten the buckle, you are going to do, the height is going to be much more. So you have to try to normalize the intraocular pressure with the saline injected inside the eye and then tighten the buckle. So that's what the procedure we do. And if it's a superior break, we can take a second call of injecting an air. And I saw one on the chat box with the air or a gas. In a buckle, it's always the air. If you want to inject a gas, it has to be a vitrectomy style. You can inject a pure C3F8 or SF6 0.3 ml. But the teaching, golden say of teaching is if you want to inject something, either saline or air. That's what we do it.
Yeah,
You know, that's exactly what we used to. This was the exact technique we used to follow in RP Center. But after I left, this is how I modified it for 2 reasons only. As you said, the hypotony, which doesn't occur in this technique. Incarceration of the retina doesn't happen regardless of how much pressure you put. And thirdly, when you cryo before, you have parallax. When you cryo after drainage, there's no parallax. The reason why in the DACE technique they said put air was because they said hypotony will occur. But by tightening the encircling band and keeping the buckle at that time, you ensure that both these things go away. You don't get the hourglass figure, you don't get excessive tightening, and you get just the right pressure in the eye.
So at Arvind, we follow most of the, it's almost similar to what is done in Shankar Netralaya, except that we don't always do pre-placed sutures. We kind of put the buckle in and then go in. But otherwise, that's a kind of, a surgeon's take. But I would also subscribe very much to, draining, putting in saline, and then adjusting. And one difference that I'd like to, highlight is that I would, all of us recommend that when you tighten, you have to tighten all 4, not just the horizontal. Because if you pull horizontally only, the cornea and the eye might become oval in shape. You're only pulling in the horizontal. So our teaching is to pull in all 4s. The entire cornea should be a perfect circle. And then you titrate and put in that amount of saline. If it's superior, like I said, put in air. Yes, air or saline would kind of keep away from gas. Because if the buckle is done perfectly, that's all the tamponade you need. You just need air tamponading for a few days. You don't need a long-acting gas. So, and of course, underscoring the fact that pre-op evaluation is the most critical step. So that's what we do. We do needle drainage. We've been doing it for 15 years odd, and we would drain in the horizontals and away from the height of the area of the break. So that is there. But to Dr. Dinesh Talwar's technique of doing cryo after putting the band, I think that needs a very high level of expertise, because it's a hypotenuse eye. In that you're putting tightening element there, and then you can have excessive buccal height. Also, you're dealing with an eye which is hypotenuse. So it's simpler and it's easier, it's safer to put in saline, get everything safe and done, and then do it. Also,
Anand, it's not hypotenuse. I'm telling you, you try it, but the buckle is there already.
No, I understand the buckle is there, but
and if you feel it's hypotenuse, one of the ways of tackling, that last bit. Supposing once in a while you have a patient who's hypotenuse, after you've tightened the encircling band and the buckle is still there. One way is that I do a sequential cryo. I will tighten 2 of the sutures away from the area where I'm going ahead and doing the cryo. So first I'll do the cryo in that area, tighten the other 2 sutures. Then if there are more breaks in the other area, I'll tighten the area which I've already cryoed and then do the other. So effectively, you titrate that the pressure should not become low. You're absolutely right. if the pressure was low, it would become a huge issue.
Yes.
But the pressure is not allowed to become low because one, you've tightened with the encircling band, you prevented the buckle, you prevented the hourglass figure happening. And three, if you still have some hypotony left, you can always tighten one of the sutures or two of the sutures of the buckle and do the cryo in the area which is not doesn't have the tightening, doesn't have the sutures now tightened. So you have just the right pressure, just right counter traction, and you don't get this hypotony. I'm just giving you a suggestion to try, because you'll actually, once you've done it, you probably won't shift back again.
No, I agree. What I think is this will work where you have detachments with moderate amount of fluids.
Exactly. So it's only
for a
meant
very
for
bullous amount, I think you
VR
still
surgery.
would need to do a
No.
lot of drainage to get things set.
So Anand, that's why in those cases I won't do a buckle. I will do a VR surgery. So I said in the beginning, any very bullous detachment, I don't consider an indication for a buckle nowadays. I will go ahead and do
So we would still do
so that's one of the differences
with where the breaks are seen. Yeah.
But that was a perfect, I think that was a perfect answer. You have to see that the height of the detachment should be moderate. I mentioned that in the beginning, actually, that one of my ideal situations is a moderate height of detachment.
And only instance where I do a cryo after placing the buckle is when you have a perforation. So when you have a perforation, obviously you have to do a cryo. But in this scenario, one word of caution is, because we do the buckles, unlike Dr. Sallam, we don't do the buckle under the microscope, we do it under the indirect. When you're doing an indirect, you inadvertently tend to push more to do the cryo because you want to see the buckle cryo effect. So what you do is in an indirect, without your knowledge, you'll be pressing more and worsening the incarceration rather than trying to treat the incarceration. So in that scenario, what I normally tell the residents is, don't do an indirect cryo. You sit in the microscope because for tagging everything, we use a microscope. I tell them, by the time when you're using the cryo for the break, you know how much time does it take to freeze. So you know a mental calculation, it takes 10 seconds or 10 counts to freeze it. So when you're going to do a cryo for the incarceration, then you don't need put an indirect because you tend to cause more problem. You sit under the microscope and you know 10 counts, just place on the right of the perforation and then make it 10 counts, then freeze it and then thaw it. So that way you can avoid an inadvertent worsening the perforation rather than treating it.
So Arvind's way of doing it would be a little different. We do all our cryos under direct visualization. So it's very important, since we're on cryo, I think that's an important point you brought up, is you shouldn't be sliding that cryo probe. You should be going towards it and, you know, going a little perpendicular to it. If you slide, that's where what Dr. Dinesh said can happen, where the cryo is happening elsewhere. So you must, the first thing I think, which I keep insisting to my assistants and the fellows, is always first check your cryo. Before you touch, check if it's freezing, check if it's thawing. If you don't do that, you can even end up with a scleral rupture. The worst thing, far worse than the cryo not working, is that the cryo is working and does not thaw. That it doesn't unfreeze, you know, it doesn't thaw. So it should always thaw, make sure. And when you go in, I think a very important thing is you just need that RP to, you should see that reaction, and only just a faint retinal reaction. You shouldn't be intense. And one very important thing is, the most important thing is the vitreous shouldn't be involved. So you should just get the right amount and then put in saline on that probe, make sure the ice is off completely, and only gently remove that cryo. Don't jerk it off. So that's where you can have a break.
One more thing, Anand, if you're doing cryo, if, as you said, you know, check your cryo, but when you're doing the cryo, if the cryo doesn't come in the normal time you expect it to come, say 7 to 10 seconds, stop, because you may be right posterior somewhere where you don't want to be. So, and recheck. Because
no. When I said check the cryo,
what
I
I'm
said
saying
check
is that
outside the eye.
I'm saying that I said check before, but when you go inside and you're pressing and you expect the reaction to come in a particular area and it's not coming 7 to 10 seconds,
absolutely
stop and check. You may be somewhere very posterior and not realizing it, because that is one hell of a risky thing. It could be the macula or the disc, which you reached because you've not bothered to see that. It's better to come back a second time rather than taking a chance on that.
Absolutely.
Yes, Atul.
The beauty of this question is, your everything is going very fine. Your cryo is coming, you have put the buckle, everything is going very fine. After cryo, you went inside and you are seeing that a young person is doing the buckle, and he's seeing suddenly lot of blood is coming inside the subretinal space. Now what to do?
Yeah.
Sorry, is question for
Are you
me?
expecting somebody to?
Dr.
Okay.
Sallam, you can go ahead.
See, one thing.
So
Yeah, go ahead.
Go ahead, please.
No,
Go ahead.
No problem.
No, that's fine. So, so this is after the cryo.
Yeah, after the cryo, you went inside. Again, you are seeing with the indirect, and suddenly you are seeing that a lot of blood is coming into the subretinal space. What will you do at this moment?
Yeah, I think if you're saying it's after cryo and not after the drainage, it's probably the sclera. There's a sclera rupture, and I think what happened is what Dr. Anand was saying is that you have to carefully take the cryo off, wait until it slows down, then take it out. Sometimes if you just pull out, you can break the sclera and the choroid. You can break the choroid. So what I would do is I would press on the eye and then inject air and wait. That's what I would do. I'll press, and as I'm pressing, I'll ask for air, and then I'll put the air and wait. I'll try also to move the eye so that the macula would not be dependent. If it's a MAC off, it is a problem. If it's a MAC on, usually the blood doesn't find its way. So those are the three things I would avoid by what we discussed. And really, if you, I would encourage, if you're doing with the indirect and you're training someone, is don't do cryo. Just leave it and laser later, because you cannot see what they're doing. Then second, I would push on the eye with cotton buds or pull on the sutures, get air inside the eye, and at the same time move the head so that the macula is not dependent.
I think, Atul, your question needs to be a little more tweaked, in as much as when you say bleed, what is the location of the bleed? Are you talking of subretinal bleed? Are you talking of intravitreous bleed?
No, sir, the blood is flowing in the subretinal space. I'm saying.
Because see, when it's see in the subretinal space, two things could happen. As Dr. Sallam said, one is you actually torn the sclera. The other thing is that there was hypotony that occurred during this process, and that's precipitated a bleed over there. These are the two things. Or if you put sutures, then one of those sutures probably has penetrated and caused a subretinal bleed. So these are the three issues which can happen. The first thing, of course, is to check that you don't have a perforation. But once you've checked that there's no perforation, the next thing is check what is the source. Is this just a place where you put some buccal sutures? If it's you put a buccal suture there, then basically you will actually be able to see a scleral show in that area where that bleeding is coming from. The one important thing is, in this situation, you don't want to drain the fluid. If you drain the fluid, the whole blood is going to clot, and then you're going to have a subretinal clot. So the better thing is to see, if it's a small amount, the better thing is to move the eye so that the blood goes into a macular, no, not sub, under the macula, inferior part of the retina. If you can avoid the macula, you really don't need to do anything more about it, but you need to build the pressure up, because chances are it's hypotony which is partly responsible. So one thing is to tighten the encircling band, provided it's not those sutures which are the cause. So you tighten the band, make the pressure normal. Now check out the source. Don't be in a hurry to drain that area. It's better not to drain that this retina. And you can go ahead and do a non-drainage, leave the fluid there, the subretinal fluid, provided it is not too much of blood. If it's too much of blood, you would have to convert to a VR surgery.
I think Atul, again, just to add to what Dr. Dinesh mentioned, I think it's good to know what's the cause, but the problem is you have to act quickly because there's no time now. You want to protect the macula and also like deal with the hypotony. So I probably would like just act on it quickly and then after that try to figure out what happened. And that's one of the dreadful situations, bleeding going on in the subretinal space.
Yeah, I think if it's a small amount of bleed, then there's no need to hit a panic button. And very often it's because of a perforation which happens, and or even the needle drainage. So if it is because of perforation while you're taking a posterior suture, then one thing we do is you can just redo that particular suture, move your buccal slightly more posteriorly to cover that area of perforation, and then redo that suture so that the buccal indents and covers that like a fresh break would. And then we talked about, you can do later then cryo to that area of perforation, so that seals it completely, so you don't have to worry. And also in either case, even if the breaks are superior or the breaks are inferior, you can just post-operatively position the patient with the head elevation, so the fluid will track inferiorly. But this is for mild to moderate amounts of blood. You don't have to worry, or this thing, that blood will get absorbed if your buckle is proper, if it's covering the breaks with the fluid. It'll take time, but it will go off very slowly, so you don't have to worry too much. But if it's a very massive amount, then you have to go in for VR surgery.
The subretinal bleed is not going to be of that issue. With the sub-RP bleed, that's what we are going to be worried about. With subretinal fluid, just like a pneumatic displacement, if you're worried about macular subretinal fluid hemorrhage, then you can just inject air or something like a pneumatic displacement, or a 0.3 ml of C3F8 and give a positioning so that you guard your macula. The most important here, the break is in the place or the site of perforation is under the buccal. So that's, if it's taken care, then the subretinal or submacular bleed, I don't think that's going to be a big problem to manage.
That means if some massive bleeding is there, if moderate amount of bleeding is there, you will just put the air and give the positioning. And if the massive bleeding is there, you will convert on table for the VR surgery.
Atul, this is a good question. So I experienced that two times. One time I injected TPA and gas, and I positioned to try to get the blood out of the macula. I think it worked. Patient had some macular atrophy, which I think was more and above what you expect for a macula off detachment. The second case I converted. By the time I converted, the blood clotted, and it was really very difficult to get the blood clot out, even through a big retinectomy. And I felt at the end, I did as much damage as if I would have left it. So I really don't know what's the best way for dealing with this. I think it's best to avoid this whole situation and not to drain every case. But I think if it happens, if it reaches the macula, it's a big problem.
And Dr. Sallam, if I can ask you, what were the reasons for those two cases? What are the reasons for the massive bleed?
A drainage.
Drainage. Hypotony. You mean to the hypotony?
Yeah, to be honest, I don't think I really went into hypotony, but at that time I did not used to inject gas, so I used to do a prang, keep pushing or pulling on the suture and putting cotton buds and pressing on the eye for 1 minute, then look. Now I learned that I inject air, then I look. But I think it's just one of the dreadful things, and the more you do, the more you're going to see that. And the best is to try to avoid drainage if you can. That's my thinking, really.
Just one more thing, Dr. Salam. Suppose the bleeding start from the supratemporal area.
Yeah.
And in front of your eyes, the blood is trickling towards the fovea. What will you do? And it is quite massive in amount.
You want to raise the pressure and rotate the head so the macula is not dependent. So you want to rotate the head so opposite to the macula.
Okay. That means you will not convert on table.
I would not convert now. I would do this. I would rotate the head, raise the pressure and rotate the head, and then be ready with air and wait. That's what I would do. And then
Dr.
see
Anand?
what happens. If I found lots of blood, then what I would do, I'll put TPA in the eye. And then if I have not put air, I put it or put gas and then position the patient to try to get that out of the neck. That's what I would do. I would not convert.
Dr.
Yeah.
Anand, what will you do?
Yeah, so if it's, I mean, I haven't really experienced this situation. I mean, with a huge amount of bleeding. One thing before we go to that, I mean, to avoid this, just struck my mind that this is something I missed saying, is that when you're draining and if it's around the position place of your buckle, usually the horizontals, just remove only one suture. I mean, loosen only one suture. Don't loosen all the sutures of your buckle. So basically, your buckle is still tight. So this kind of massive situation can only really happen if you've got hypotony. If you've hypotony precipitates this kind of massive bleeding. Otherwise, you would not get this kind of massive bleeding. Even if you perforate and touch the retina, you will not get massive amount of bleeding. A massive bleeding is like a it's like a decompensation, suprachoroidal hemorrhaging. So this kind of bleeding will not happen unless you're draining in a hypotonous eye. So the key thing is to avoid that hypotony. And I think, like Dr. Salam said, immediately changing over to a high IOP situation can help tamponade that bleed. So I would, first do that. Then, like you mentioned, rotate the eye if at all, and keep the pressures up. And then you can, of course, add in air. But then again, there's only that much of air you can add in if you're not going to vitrectomize the eye. There's only a small amount that you can put in. So I don't know how effective that will be. Perhaps if you mentioned that the break is in the superotemporal quadrant, then perhaps the air bubble can only be positioned so that it pushes against that area from where it's bleeding. But beyond that, there's not a lot you can do. You have to, at some point, if it's so massive, I would think you would need vitrectomy at some point later.
In fact, your suprachoroidal detachment itself will act like a buckle. Post buckle, sometimes when you see a choroidal detachment, you're actually happy because that gives a double buckle effect. Apart from your buckle, this one also will give a buckle effect. And
the problem is usually not with the tear. The problem is with the problem of the blood reaching the macula. But the tear is usually going to be well looked after, as Dr. Anand was saying.
And as both of them mentioned, I also wouldn't converge immediately. Just like the dictum which says when you have a suprachoroidal hemorrhage and a cataract surgery, you don't proceed. You would like to try to close it and have an airtight compartment or watertight compartment. You don't want to meddle with anything. Similarly, when you have a suprachoroidal hemorrhage on the table with the buckle, just close it. Just close it and then come out, and you can always do it again. Because going in the eye with a suprachoroidal hemorrhage inside the eye is going to have equally more messy and more problematic. And you're trying to drain the suprachoroidal hemorrhage, it's going to have more and more bleeding. So when you have a suprachoroidal hemorrhage, just the golden thumb rule is just close it and come again. Do it again.
And one of the
that's why the first thing I told you, I put the encircling band buckle sutures first. The reason is you can tighten it, and you can tighten it to make sure, and that you can tighten it at a second's notice. So you don't let hypotony ever occur, and that's the first thing, prevention. As Anand said, it's actually hypotony which can induce all these things. If you don't let hypotony occur, you will not get this problem. So the first thing is, don't let any hypotony occur. If you feel the pressure was, and now you're seeing a little bleed occurring and there's hypotony, tighten the encircling band immediately. The moment you've tightened it, your pressure is built up, fluid is still there. As I said, I would not remove this fluid now. And, as was being discussed, better to leave it to fight another day. Even if it's a moderately large subretinal bleed, if it's mixed with SRF, usually it will not clot significantly, and it may go down. So position the patient. You can go down a day or two later for you doing your VR surgery. As Dr. Salam said, you go immediately. The moment you drain that fluid, it will also clot. The blood will also clot. Now you have a clotted blood which is entangled over there. It's not easy to bring it out. You do too big a retinectomy, it will pull the retina. If you do too small a retinotomy, if it's a small retinotomy, it may or may not come out through that. So the better thing is to wait for a day, let the thing settle down. Only the part, now you only will have to remove that part which is in the macula. You won't have, the rest will be anyway down. And most of it will be fluid blood. It'll be mixed with, it will be liquid blood. So that's one aspect of it. The second thing is, if you said that is coming from one of the sutures, now, as Anand has already told you, you have to remove that suture. The important thing when removing this suture is, don't move back. like your sutures coming out, there's a tendency to pull it out like that and yank it out. You will cause more choroidal chaffing and a bleed through that. So just cut it, flush, and extend it in the direction in which it came, from the direction in which came, towards the needle side, not towards the opposite side, not towards the suture end side, so that it just moves out in the same direction through which it has come. Just like any thorn, you never take the thorn out from the wound of entry, you create a new wound of exit. So similarly, let it come out through that other end of the wound, and then you put your new suture more posteriorly. That he's already told you. So once you've done that, there isn't any issue. Incidentally, even cryo is only needed if that was attached retina. If it was detached retina, it's still in subretinal space. What are you crying? What will you cryo? There is no tear there. It is only a bleed that has occurred. There is no break over there. The break occurs if you end up doing this kind of problem, if you perforate in an attached retina. If you perforate it in an attached retina, yes, you have to cryo that, which is not a difficult thing, because you don't even need to actually localize too much. You can actually go exactly to the point where that suture is, and cryo in that area for 7 to 10 seconds, and it will cover that area. You can check later on. You would have got a mild cryo in that area, and you're done. So the basic problem of bleeding, you're absolutely right. The thing that scares everybody about a buccal is bleeding. Two levels of bleeding. One, which is common, relatively more common, is subretinal bleeding. Still rare, but relatively more common. Second is suprachoroidal, which is exceedingly rare. But if it occurs, it needs to be treated like any other suprachoroidal hemorrhage. Leave it alone at that time. Come back later on after 7-8 days. So this is the difference between the two types of bleeding.
So it's almost like in cataract surgery, like Kasi was saying, the expulsive or the external bleeding is not because of the high IOP. It's not because of the high IOP. It's because of a rapid decompression of the eye.
Yes.
Rapid hypotony. It is not the high IOP which causes it. It is the opposite. It is the sudden decompression, and the first thing they say is close the eye. So you maintain.
And the sudden decompression occurs when you're doing SRF drainage.
Correct.
And especially if you've been pressing from one side and somebody just starts the drainage, and as a gush, the fluid comes out. That's when you'll get this problem.
Another word of caution about this.
And the other thing is, if the patient is a high myope, you should take all precautions to prevent any hypotony for even a few seconds.
And other thing, because we're talking about perforation, it's important how you hold the needle holder. Because most of the time in a buccal, you need to use a Carl's needle holder rather than a Baracker. Because Carl's has a locking mechanism in it. You need not focus too much. Whereas in a Baracker, there is no locking mechanism. So use the Carl's needle holder. And always the suture has to be in tangential or parallel to the globe, not opposite side. So if you're doing infratemporal, your hand should not come from outside to in. It has to be parallel to the surface of the globe. If you're doing parallel to the surface of the globe, the chance of perforation with the needle is very less.
Especially with the microscope.
Yeah,
in today's microscope era, the chance has gone down tremendously. I can tell you, we used to have a lot more perforations when we were working without the microscope. And now it's very rare to get. I mean, you can always get. I mean, now one should never be complacent.
So you have to have it parallel to the globe, tangential, not on the other way around.
Okay, after all this point about during the buccal surgery, 1 or 2 point after the buccal surgery, off and on we are seeing means 3 monthly or 6 monthly, we are seeing buccal erosion or buccal infection. What is the best way, whether to take out the buccal and all the sutures, or we have to take out the buccal and leave the sutures there?
Atul, before you come to that, why not prevent it? So the first question is, can we prevent it?
Okay, sir. Sorry, sir. Sorry.
Because we need to have a 2-layer of suturing. In a buccal, you just not have to have a single layer of suturing. Buccal is most important is 2-layer of suturing. First, you have to suture the tenons over the buccal and then do the conjunctival suturing. And most of the time, the peritomy, we give a long peritomy cuts, the nicks in the peritomy, conjunctival peritomy, we give 2 horizontal cuts perpendicularly across, 90 degrees across. You ensure these 2, because that's why we say buccal, you need a lot of planning. Wherever you want to give the initial nicks, make it always away from where you want to put the buccal. Because in a buckle, you need to have a long, wherever you give the long nicks, which is around 7-8 millimeters from the limbus, make these nicks away from the area of buckle so that you don't need to suture over the buckle, because that's where the exposure happens. So you pre-plan it having the nicks 90 degrees apart, which is away from where you're planning to put the buckle, and then close the buckle with at least the buckle area with 2 layers of suturing, one with tenons and then the conjunctival closure. So these 2 ways you can prevent the buckle exposure and extrusion.
When you cut the suture, when you cut the conjunctiva initially, make sure that you take the conjunctiva and tenons where it's fused together in one bite, in one cut. That makes it easier to bring both the layers back together. Otherwise, the tenon will slip back and you'll have a lot of problem doing this. It's easier said than done doing 2 layers suturing. It's easier if you manage to keep both the layers together. So you have them close to each other, and only in some area you may want to put 1 or 2 holding sutures to bring it together. This is especially important in old individuals. In old individuals, the conjunctiva is actually very thinned out. So you have to be even more careful not to be buttonholing the conjunctiva in different locations. And then you have to be careful to, in that situation, it's very important to bring the tenons up specifically in the area where the buckle is. You know, as Kasi was saying, the most important area is actually the area where you've got the buckle, because that's where it otherwise erode through. So that you must take care of. So first thing is how you suture, and make sure you do a relaxed apposition. What happens is people find that there's a little, it's a little tight, it's not coming. So they just pull it and put the suture. It will give way. Finally, you're going to, you may even have a retraction of the conjunctiva. So it should come without any tension on the wound line. It should come they should oppose without any tension on the wound line, and the conjunctiva should come into its place. Now the question comes before, and now one more thing before you're doing the suturing, we actually irrigate with antibiotic also. It's something that we've been doing for a long time, and I think it's made a lot of difference to our incidence of wound infections. So I treat others' wound infections. I've, touch wood, not been, I've not been unlucky that way, that I've had my own wound, buccal infections. So that irrigation in all the quadrants is another important factor. So after you've done that, then you come to this, and Kasi can start off with how to manage.
One thing is, be generous with your relaxing cuts. Don't be very mean. If you feel that you give a small relaxing cut, what happens is, while you're doing the buckle, while you're passing the band, or while you're placing sutures, when the sister is retracting, the conjunctiva is going to tear irregular.
Yes.
Most of the problem comes when the conjunctiva is so irregular. So be generous in a relaxing cut. Even it goes up to the equator, no problem, because it's going to be away. As I said, it has to be planned in the area which is away from where you're planning to put the buckle. So be generous in a relaxing cuts. That's one important point. And as Dr. Dinesh has rightly said, after the putting the buckle, everything, we irrigate the entire area with an antibiotic solution. And once the buccal infection comes, it doesn't mean that every time you have to go and remove the entire buckle. See, if you have to remove all the sutures and all the buckle. That's the perfect way. But it doesn't mean like that. If you have one suture which is extruded, just try and remove the suture, that suture alone. Or try to, that's why in a buccal sutures, when you put the suture 40 or 50 Dacron, what I make sure is, because most of the time when you cut very close to the knots, our tendency is to cut close to the knots. When we cut too close to the knots, the two ends are going to be protruding like this. So what I do is, I leave it long. I leave it long in a buckle, a long end from the cut ends. So that then these two free ends, I slide it under the buckle. So under the tire, I slide these two long ends. Because you have a short end, it's going to protrude like this. When you have a long end, I can just push it under the buckle. So that's one way I prevent the suture exposure. So if it's a buccal exposure, you see conjunctiva is a lot of laxity is there, no other choice. So either you have to do a conjunctival grafting over there, or you have to remove the buccal. If it's only a suture exposure, you can try to trim it and then try to push it. If it is not possible, just remove that suture alone should be fine. So that's why that suture is fine. If despite that, again and again, there is going to be granuloma or some problem, then you have to remove all the sutures and buckle. That's why this is one area of VR surgery where a buckle diagram is very important. Because most of the time, sometimes you don't do the buckle removal, someone else would have done it. having a buccal diagram is very important. That tells you how many sutures are there and where is the band type. Because before removing the buccal, first thing you have to remove the band. Without removing the band, if you're going to pull the buccal, you're going to cause a lot of problems. First, you have to remove the band. So you need to know where the band tie is, whether you put a suture or a sleeve. That's why having a buccal diagram is very important when you're planning to remove the buccal or doing something with an infection.
Yeah,
fact,
excellent
we need
points,
to
I
know
think,
where is
by Kasi. I just like to add that, we can't understate the importance of conjunctiva management. So very important point, make large generous nicks and don't do it hesitantly. Do it in one shot. It should be a clean cut. And that's important because that's exactly like what Kasi said, you need to retract the conjunctiva. If you make very small hesitant 3 mm, 4 mm cuts, you are going to make that ragged. And then it's a nightmare at the end of the surgery. Secondly, when you are planning the closure, your buccal, your eye is going to be protruded with all the pulling and stuff that's been happening. So with two cotton buds, just place it on the buccal, on the eye, and push it gently inside the socket. The conjunctiva will automatically beautifully come close. And then before you start your suturing, bring the ends of the conjunctiva and place it with your forceps and see them opposing themselves. And then you just probably you just need to do 2 or 3 sutures, maybe 2 on either side, to get it opposed. About suturing in layers, actually that's easier said than done. And in most of the elderly people, the tenons is, the conjunctiva and tenons is, very thin. It works really basically for young patients where there's a healthy, thick tenons. There, yes, you would need to do so. Also about the issue about, and of course, it's in Arvind, there's been for decades the practices to put in antibiotics before closure. In all 4 quadrants, we inject a little bit in all 4 quadrants. So that's the standard procedure. And about infections, also please remember that especially when you have an encircling element, very often, and if it happens, months or even a year later, the infection or this thing, very often there's a fibrous capsule over the band, over the buccal. So it's not easy to remove a buccal. And in fact, if it's a chronic case like that, I've actually had on standby scleral grafts ready in case you have, some dehiscence somewhere. You can even have that. So you should be prepared. I'd like to have a graft there in the very, very rare possibility that while pulling, you can have a little bit of dehiscence, especially in myopes. Having this situation in myopes is a nightmare. So that is very important. And like Asi said, suturing is very important. If you cut the buccal sutures very close, they'll stand up like a mustache. And that's the site of erosion. So always have it, be a little generous, leave a little bit of length and you can tuck it like that, or you can just leave it there. It won't do anything as long as it's not standing up. Sometimes if it's an offending suture, you can just remove that and you can actually start with antibiotics and you can again go back later. If that doesn't work out, then you can kind of remove the buccal. So that's what I would do.
One tip regarding the buccal, the sutures, the protrusion. See, so what we do is when we, after tying the buccal, tying the suture, at that time it's somewhere in the middle of the buccal area. So I will pick it up with the needle holder from one side and forceps on the other side and bring the thing around and take it down to the posterior end. So once it's in the posterior end, it's actually almost 18 millimeters behind, and there the erosion doesn't occur. The erosions occur if you've left the knot on the anterior side. So in all cases, we will rotate it and push it into the lower part, in the posterior part of the buccal. So it's no longer exposed. Of course, there's another advantage we have. We are using silk. So silk actually doesn't cause, it doesn't come out. It doesn't come as a protruding. The maximum protruding occurs with Merceline and things like that. So we don't use that.
And to handle the conjunctiva,
if you're using Merceline, it is definitely important that you push it back. You take it into the posterior part of the eye and leave it there, so that it doesn't stand up.
I think the simplest thing would be to suture at the posterior end. Do not put your sutures in the anterior part. It's that simple. Because sometimes
when you tie, you can't control it so much.
Yeah. Sometimes rotating it after you put the suture may be more difficult. So ideally, plan to pre-plan. Plan to suture.
Well, if you can do that, that's great. Yeah, if you can do that, that's great.
That's
but
our standard
what
practice.
we do is we always, wherever it is, we just rotate it to the edge. So it's easier to finish off there.
Then don't use a tooth forceps for conjunctiva. That
Yes.
will cause button bowling. Use a serrated forceps.
Also,
Correct.
don't use a tooth
Correct.
forceps for the holding the suture. The suture will also fray if you use a tooth forceps. All these things are with serrated forceps. Whether it's the conjunctiva, whether it's the suture that you are holding, use only serrated forceps for them. Nowhere do you use tooth forceps.
Atul, we have something in chat box. We can ask the chat box one question each.
Hmm.
Yeah, I
Kasi sir,
think there are a
you
lot of
start.
questions. Yeah.
Kasi sir, you start.
No, chat box. I am not seeing
Yeah.
the chat box.
Dr. Ganesh
Okay,
asked,
I'm seeing.
Dr. Ganesh asked, Sohila, does glaucoma change your management option in choosing vitrectomy or buckling? Glaucoma.
Yeah. Dr. Sallam, you want to answer that?
Sure. Which one? The management change? Does
Yeah.
glaucoma change your way of managing choosing vitrectomy over buckling? Maybe. I mean, I think my indications for scleral buckle are solid, the young patients. So usually whatever they have, and I don't encircle, so I really don't have an issue with glaucoma. I use a small buckle. I don't encircle, so probably it's not going to change things much for me.
Actually, if the patient has had a surgery, a glaucoma surgery, then I will not do a buckle.
Of course.
I will do a vitreoretinal surgery. And I will do that vitreoretinal surgery without any band or anything also. So I just do a straight vitreoretinal surgery. If you're talking about a patient who has glaucoma, the only issue would come if the patient is on, say, 4 drugs for glaucoma, then you would need to be careful, about not letting the pressure go up at any time during the procedure or subsequently. So you would leave it at a little lower pressure. The second thing would be whether we want to leave the conjunctiva for a trab. But recently, I think we've had a discussion on this, that the glaucoma people say that they are much better off if you made your peritomy at the limbus rather than leaving a frill, because the frill tends to actually have only that 4 millimeter, and after that the rest of it scars at 4 millimeter, making things even more difficult. So this is something, maybe I would ask my glaucoma surgeon at that time which way he wants. If he wants me to spare a particular area, in that area I would leave a frill. In the rest of the area, and maybe I'd make it even bigger, maybe 6 millimeter away, and in the rest of the area I would go ahead and make a limbus space.
So I think it also depends on how advanced that glaucoma is. If you're talking of a 0.9 CDR with a bullous RD, then I know this patient is at some point of time going for a trab. If not a trab, then the tubes. For which case, buckles are a problem. Okay, and this is where perhaps a segmental thing, especially if it's in the inferior quadrants, that would work, because draining a huge amount of fluid will cause that decompensation hypertony, and then that will cause some sort of a snuff out. These kind of cases, now given the advancement of vitrectomy and how minimally invasive it is, I would go in for vitrectomy, especially if it's advanced, and also more than anything, it spares the conjunctiva.
Because I would get the concurrence from the glaucoma, because I'm sure my glaucoma colleague is not going to spare me if I'm going to touch the conjunctiva. They will always want to have an intact conjunctiva. So
Absolutely.
most of the time, if it's a glaucoma pre-existing, the risk is going to be same. As said, if you're doing a buckle and going to do a drainage and causing an hypertony and causing a wipeout phenomena, or during a vitrectomy, you're going to have some fluctuations in IOP and then causing some wipeout phenomena, the risk is more or less going to be the same. One thing is you just get a concurrence with your glaucoma colleague, whatever you want to, and then a proper counseling. Most important here is proper counseling the patient. We have to tell them all the risk involved with the wipeout phenomena, whether it's going to be a buckle or a vitrectomy. Proper counseling is much more important.
Yeah, and importantly is with vitrectomy, the IOP is in your control. And especially given the IOP control that most of the constellation, which is what most people use,
but
has in your hand.
Don't have.
Yeah, many machines don't, but to a greater extent, it's in your control than in a buckling surgery.
Yes, Atul.
Dr. Kaushik, any other question?
All other questions have been answered by Dr. Ahmed Sallam in the chat box.
Okay. Then we can wind up.
Yes, if you wish.
Yes. Unless you're sending dinner over.
No, no.
Unless you're sending dinner.
It depends upon the speaker and the panelist.
The buckle is a separate topic on its own. We used to have in Czech and
Very vast
Italia
topic.
entire 1 month. 1 month we discuss only buckle modules. Opening and conjunctiva will be one class. Opening the conjunctiva will be a class of its own. First, how to open, then what are the complications on opening. So each step we say how to do it and what if something goes wrong. So it will go on for an entire month. The entire module goes on for a month. So it's such a nice topic, and thanks Atul for making us to revise our buckle. It's quite some time since I've done a buckle off late.
No,
It's
it's
like revising.
critical. I think it's critical. They've done a great job, putting this up.
Yes.
This is a real need of the hour.
But buckle, the only advantage is if the next day or maximum say 24 to 48 hours, if the retina attaches, it's 99% or even 100% success, you can say. Unlike the vitrectomy, you have surprises after a month. So buckle is still a beautiful surgery. And you know that 24 hours, you know that you have done a wonderful job. You don't need to have much, and you will not have much surprises after a month. So that way, I still believe buckle is one of the best surgeries, and the success rate of buckle is definitely in a proper case, in a given case, which is more or less comparable, like an anterior young person, you do a buckle, you do a vitrectomy, 100% I'm sure still buckle scores much better than a vitrectomy.
I think Dr. Salam also made the same point. A buckle, once it's set for life. Vitrectomy, you can get surprises down the line, especially if you're putting in oil.
And specifically, if you've left a little bit of fluid at the end of surgery, and the next day it's gone. One is you've done a drainage surgery, but even in a drainage surgery, you've left a little bit of fluid. If you've left a little bit of fluid and it's gone, now you know you've got 100% success. This is not going to go away.
And unfortunately, now people are all moving towards vitrectomy. All sutureless, all 23, 25, 27. Buckle as an art is like slowly fading away, but I'm sure it has its own indications.
Yeah. I think basically it's because of the fear of these two things only. You feel a little less in control. So the hypotony and the consequent risk of hemorrhage are the two things which scare you. Incarceration, frankly speaking, is no longer much of an issue.
Because maybe the current generation is believe in what they see. In buckle, only the surgeon sees, but rest of them, they don't see that much. That's why maybe the buckle is a fading art.
It's also a back-breaking art.
Oh,
Yes.
absolutely. Yes, very much.
And still in this part of the world, buckle is done with an indirect. Dr. Salam, we don't use a microscope. We still use an indirect. A good indirect microscope is a prerequisite for doing a buckle.
Absolutely.
If there are no other questions, or do we have another topic?
No.
I'll take this opportunity to thank Dr. Ahmed Sallam for giving an excellent talk, and I think we learned new things today. I'll thank Dr. Dinesh Talwar sir, who is one of the most senior vitreoretinal surgeons in India, for sharing his insights on buckling. Thanks Dr. Anand sir for sharing the tidbits of the buckling surgery, specifically managing the subretinal hemorrhage part. That is what we fear, but we know as surgeons, if you plan carefully and if you do not allow hypotony to happen, mostly the subretinal bleed will be manageable. It doesn't increase much if your pressure doesn't go down. And thanks Dr. Kasinathan sir for sparing your valuable time. And we had an excellent panel, and I'll thank Dr. Atul Dhawan for arranging all the speakers and all the panelists, and I'll also thank our audiences for staying so late for this topic, and I'll ask Dr. Atul for the final comment, and then we'll conclude.
Thank you everyone for the excellent presentation and excellent discussion, and hope the people will go and start doing buckling more often in all the young cases. Thank you, Dr. Salam, Dinesh sir, Anand sir, and Kasi sir for this wonderful lecture. And now I would like to introduce our next speaker, Dr. Rajiv Muni, and he will give a talk on the pneumatic retinopexy. Thank you all.
Thank
Thank
you.
you so much.
Thank you.
Thank you, Atul.
Thank you, Dr. Salam. Thank you,
Thank you. Thank you
Dr.
so much.
Dinesh, Kasi.
Thank you.
Good night.
And Dinesh,
Thank you,
sir,
Atul and Kaushik. Yeah.
Thank you, Atul. Thank you, everyone. Bye-bye.
and the team ASD for having such a nice, wonderful,
Yes.
educative initiative.
Yes. Great job.
Thank you. Good day.
Good night, sir.
Good day.
Okay, sir. Great day.